Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. In the last two sessions, we have discussed about the definitions and etiological factors for development of acute liver failure. So today I'll be discussing a case followed by how to investigate and interpret the results in the case scenarios and some MCQs. So this is a case scenario. A 24-year-old woman presents with malaise, nausea, confusion. LFT shows AST 4200, high sky, bilirubin is 1.2, INR is 3, serum ammonia is 98. What is the most likely diagnosis? So, by definition, acute liver failure is an acute insult to the liver, evidenced by elevated transaminases. So here you can see very high transaminase. So there is an insult to the liver is present. Second point is look for coagulopathy. Here the INR is more than 1.5. So here it is 3. So coagulopathy is there. And patient has got confusion. So the one of the early evidence of hepatic encephalopathy. So this patient is an acute onset, less than 28 weeks. You can say the patient has got an acute liver failure. Hope this explanation is clear to you. So today's learning objective we have already discussed. So just to recap the acute liver failure. So 3 points. One is acute insult, that is less than 28 weeks, elevated transaminases, INR, that is coagulopathy more than 1.5, and features of hepatic encephalopathy. Hepatic encephalopathy we discuss in another session. So ALF is a acute liver injury, and the clinical clues are usually there is a non-specific symptoms like features of encephalopathy, jaundice, and features of cerebral edema. So these are the clinical features. So the mnemonics to remember we have already mentioned the last session, divided into parenchymal and the vascular causes. Vascular, most important, is ischemia, and second comes the hepatic vein occlusion due to polycythemia, malignancy, other thrombophilic states. And the mnemonics for ischemia is shock, sepsis, hypertension, obstruction, cardiac causes, and a combination. Parenchymal, we have already mentioned the VIP, B for virus. Among the virus, hepatitis B virus, hepatitis E, especially in pregnancy. Other viruses we have mentioned, alcohol, drugs, and toxins. The toxins, always remember, Amanita phyloides, that is the, so this is how. So now we are going to how the basic diagnostic workup. So first you look for evidence of liver insult, injury to the liver. You go by the aminotransferases. AST and ALT are markedly elevated. The pattern can sometimes hint the etiology. More than 3,500 most often seen in acetaminophen toxicity, unless it is due to the viral hepatitis or due to the shocked liver, etc. Bilirubin may be low initially in acetaminophen, rises later. Alkaline phosphatase is low in Wilson's disease. Albumin will take some time because the half-life is long. So first we look for evidence of liver injury. Second is we look for the coagulation profile. Prothrombin time INR is diagnostic criteria. And the best thing will be you do for thromboelastography. So it may show normal or hypercoagulable in the presence of high INR. So the patient can develop features of bleeding manifestation and thrombosis. That's another point you should keep in mind. That is, they say, because the protein C, protein S, and other factors are also produced in the liver. So sometimes it may be hypercoagulable in the presence of increased INR. Now we think about the look for hepatic encephalopathy, clinical features of hepatic encephalopathy. What are they divide into grade 1, grade 2, grade 3, and grade 4. Grade 4 is coma. Grade 1 is inattention, euphoria, anxiety. The most important is altered sleep pattern and decreased attention. So inversion of sleep rhythm can occur. So the patient may sleep during daytime and they will be awake at night. So that is one thing usually you get in. What that point is clear. In grade 2, the most important you look for the hysterexis, that is flapping tremor. And there can be disorientation, personality changes, and sometimes the plexus may be hypoactive. Okay, and grade 3, there is a somnolence, patient may be responsive to stimulus, disoriented, hyperactive, DTR. So this is the West Haven criteria. The West Haven criteria. So remember this. And what is the mechanism of this hepatic encephalopathy? Hepatic encephalopathy occurs when the liver is failing. Liver fails to convert ammonia into urea. So what happens? The blood level of ammonia increases. So this will reach the brain, and the astrocytes take it up, and the glutamate plus ammonia, it converts to glutamine. Glutamine is osmotically active, attract water, and this will lead on to increase in the intracranial pressure. So the clinical features of hepatic encephalopathy are mainly due to development of increase in intracranial pressure. In grade 1 and grade 2, it is less common. But a significant portion, 25 to 35% in grade 3, and up to 65% of patients with the grade 4 has got raised intracranial tension. And one of the cause for mortality is increased intracranial pressure. In addition, another important thing you look for is the metabolic and kidney functions. Check the electrolytes. Hypoglycemia is very common because liver produces glucose by neoglucogenesis, glycogenolysis. Hypokalemia and hypophosphatemia. Ammonia is elevated, and this correlates with the hepatic encephalopathy. So here in our patient, ammonia is elevated. Renal function, rest, creatinine, blood urea nitrogen, because up to 70% can develop acute kidney injury. And lactic dehydrogen is elevated when there is a ischemic injury. So basically, these are the tests that you do. That is, look for liver injury, look for coagulation profile, look for the metabolic and kidney function, along with this, check the ammonia. Now go for the specific clues in the etiology. So as mentioned, acetaminophen, usually the AST/ALT will be very high with a low bilirubin. So in our patient, the serum bilirubin was fairly within normal limits, but the enzymes were very much elevated. Ischemia, again, you get a very high AST/ALT, and the ratio, and you can get a high LDH. Hepatitis B, again, the transaminitis is there. Wilson's disease, low alkaline phosphatase, and you can get a Coombs negative hemolytic anemia. HSV, marked transaminitis, low bilirubin, leukopenia. And again, if there is thrombocytopenia in a pregnant patient, think about the HELP syndrome, acute fatty liver disease. So these are certain clues that will help to make a diagnosis. Then imaging, of course, you have to go for an ultrasound. You may go for a Doppler study for the portal vein thrombosis and hepatic vein thrombosis. Viral markers are essential. Hepatitis B, HSV, PCR can be done. Autoimmune markers like ANA, anti-small antibody, suppose you're suspecting Wilson's disease, go for ceruloplasmin, serum copper. Drug levels must be checked. And whenever you suspect a drug, young patient comes, paracetamol poisoning. EEG can be useful when there is a patient has got a prolonged coma, maybe septal seizure. CT and MRI, when there are signs of raised internal tension or the patient is remaining unconscious, you may go for an imaging study. What are the prognostic markers? The prognostic markers are serial INR. It indicates a poor prognosis. When transaminase sudden drop can mean recovery or massive necrosis. Hyperphosphatemia may signal regeneration. Renal markers, again, acute kidney injury is seen in about 70% of patients, and it is associated with a increased mortality. Now we go to the second case. A 19-year-old male has got confusion, jaundice, and mild hepatomegaly. AST is 350, ALT 120, bilirubin is 14 milligrams elevated, alkaline phosphatase is 35, hemoglobin, there is anemia, which is Coombs negative, INR. So patient has got a coagulopathy, that is INR more than 1.8, has got a confusion, probably hepatic encephalopathy, there is a transaminitis, so patient has got acute liver failure. What test you should do urgently? In the presence of anemia, think about a hemolytic anemia. So last time we have mentioned the causes, vascular, parenchymal. Think about the parenchymal, virus, infiltration, pregnancy, alcohol, drugs and toxins. So what is the likely cause in this patient? Ischemia is unlikely. So specific clues I already mentioned. So low ALP and Coombs negative hemolytic anemias are clues for Wilson's disease. So remember, young patient coming with an acute liver failure has got anemia. Think about Wilson's disease. So you have to check for the serum ceruloplasmin and urinary copper and suspect Wilson's disease. So Wilson should be in the differential diagnosis of a patient, young patient coming with the jaundice. Now we'll go to a simple case. Postpartum, right upper quadrant pain, elevated AST, platelet is low, INR is high, so patient has got coagulopathy. What is the likely diagnosis? Very simple. So it's a pregnancy related. It is either HELP syndrome or acute fatty liver pregnancy. Here you can see the platelet count is low. So this is a point more favoring HELP syndrome. So now we go to assertion reason type of questions. Question number 1. Patients with acute liver failure always have hypocoagulability due to elevated INR. Reason: INR reflects synthetic dysfunction, not the balance between procoagulant and anticoagulant. This reason is correct. INR reflects only synthetic dysfunction. So in this question, not the balance between procoagulant and anticoagulant factors. So what is the correct answer? Assertion: patients with AL always is false. Reason is correct. So they have got someday, most often in the presence of increased INR, some days they can have hypocoagulability. That is why I told you earlier, the ideal test would be thromboelastography. So despite high INR, thromboelastography may show normal or hypercoagulable state. So remember this point is a balance between, is a synthetic dysfunction. So that can be procoagulant or anticoagulant factors may be affected. So this acute liver failure can present with thrombotic complication and also bleeding manifestations. Next assertion reason: very high aminotransferase levels with a low bilirubin suggest acetaminophen toxicity. This is a point to be remembered. There is a low, the first case we have seen, very high transaminases, but the bilirubin was fairly normal. So acetaminophen overdose, massive hepatocyte necrosis occurs rapidly before significant bilirubin develop. So both assertion and reason are true. Question 3. Assertion: hyperphosphatemia in ALF indicates poor prognosis. Reason: hyperphosphatemia is due to ongoing hepatocyte necrosis. I already mentioned that hypophosphatemia occurs during recovery. So hypophosphatemia indicates a recovery stage. So it is not due to hepatocyte necrosis, it is due to degeneration. So both assertion and reason, both are wrong. Hope this point is clear to you. So in this session, we have discussed about the approach to a patient, how to do the investigations and interpretation of the results with certain case scenarios. Stay tuned for further videos. Thank you.